Welcome to Alzheimer Speaks Radio. I'm your host, Lori LeBay, and I'm so excited that you're joining us today. We are going to have a fascinating conversation as usual as we learn from people all around the world at all ages and stages of life. Stay tuned as we shift our dementia care from crisis to comfort.
Here we go. What you think about, you will bring about dementia change. We will.
Well, hi, everyone, and welcome back to Alzheimer Speaks. Today, we're going to have a really interesting conversation. We're going to talk to a couple of professionals in the industry, as well as a person living with dementia, about the new blood test to diagnose Alzheimer's. And we're going to learn a little bit more about that. I also did a query asking for people's questions, so I'll be filtering those in as well during our discussion. So I hope you'll learn as much as I'm hoping to learn out of this. But before I introduce you to our guest today, I always like to give a couple of shout outs. So first, I always want to point people to AlzheimerSpeaks.com. There we have a ton of free educational resources, so please don't miss those. We've been curating this information since about 2008. My own mom lived with dementia for 30 years, so I get the importance of awareness and education. I also ran across a wonderful product and company called Twiddle. And Twiddle has some sensory products that are absolutely fantastic if you are dealing with sundowning or any type of anxiety. It could be for a drive in the car, going to the doctor. Anytime somebody gets a little fidgety, they are wonderful. They also have a product called AdaptWrap. And so grooming and getting dressed can be complicated, and sometimes people don't understand or they don't have the muscle control anymore. So go to the number 4 and then twiddlesplural.com to learn more about their products. I also want to mention Maud's Awards. Now they have already, closed the chapter for their awards, and they'll be announcing those in the coming months. But if you work in the industry and you've done something you think is pretty cool, go to maudsawards.org to get more information, because maybe you can apply next year. They have an award for $25,000 and another one for $5,000. And then 2 other things I think are really important are just support groups, having people engage with one another. And on Wednesdays, the 2nd and the 4th of each month, I do a memory cafe called Arthur's Memory Cafe, which is open to anybody globally. We meet from about 1 to 2:30, and that is Central Time. And then if you're in Minnesota, I also partner with the Shoreview Community Center, and we do what we call a Caregiver Connect. And that runs from 10 to 11:30, and it also offers respite for people. If you're interested in either of those, just reach out to me at Lori, Lori, at Alzheimer Speaks, or you can just go to alzheimerspeaks.com, click on the contact us, and contact me that way. And then, of course, I would be amiss if I didn't mention Dementia Map, our global resource directory, which is free to use. You don't have to give us any contact information. So feel free to check that out too. That is dementiamap.com. Now, with no further ado, let's go meet our guest. Well, I'm so excited to have our panel together. This is a hot topic we're going to be talking about with blood tests. So what we're going to do is I'm going to have everybody introduce themselves first, and then we'll get off and running with our questions. So Dr. Teodora, you want to go ahead and introduce yourself?
Sure. Nice to be here, Lori. Thank you. So I'm a medical science liaison. I work for ALZpath, which is a diagnostic solutions company for Alzheimer's disease. And I have a strong neuroscience and science communication background, and I work with clinicians to provide valuable resources and information about ALZpath's products. And we will talk about the blood-based biomarker that we provide for Alzheimer's disease and related dementia.
Great, thank you. And Dr. Wren, how about you?
Hi, I'm Lawren Vandevrede. I'm a cognitive behavioral neurologist. I specialize in folks that have thinking and memory problems. And I'm here at UCSF, where I'm a physician scientist. I do a lot of work with clinical trials and biomarker validation, implementation, trying to kind of bridge the gap between the research world and the clinical world and usher in some of these exciting findings we have so that they can actually benefit patients who I enjoy working with directly. So thanks so much for the invitation. I really appreciate it.
Great, wonderful. And Ginger, do you want to introduce yourself?
Hi, I'm a 87-year-old retired speech language pathologist who about 10 years ago, I ran through a bunch of diagnoses, including it ended up with Lewy body dementia, but for some reason I got better and now it's mild cognitive impairment.
Thank you. I always like to hear from our panelists if they've been personally touched. And Ginger, you already said, that you have been, so we'll kind of leave it at that. Teodora, you want to go ahead and tell us if you've been touched personally?
Yeah, so thanks for that question. It's interesting because usually you hear all these science panels and nobody throws in a personal tidbit, so this is nice. I have a stepfather whose family, he has a family history of Alzheimer's, and I had the pleasure of meeting his mom in a facility before she passed. And I was in graduate school at the time for neuroscience. And it was very nice to see, oh, this is what actually happens in the brain, and not just reading it in a book. And it was very dramatic seeing it and not seeing, the mother not being able to recognize her son. And after my graduate career, I went into Alzheimer's work, partially because of that.
Okay, great. Wren, how about you?
Thanks again, Lori. It's a great question. As Teodora said, it's, I think, pretty common to find people are touched by this disease that are working in the field to try to find a solution. And for me, it was my grandmother. When I was a young man, she began to get sick. I was working in a care field, actually, with developmentally disabled, mentally ill individuals, and it was identified that there was additional help needed. And so I kind of moved from Michigan to Florida to take care of her and kind of saw the disease up close and what it did. And it kind of put my feet on this path, to try to improve the care of folks with dementia, try to do it a little bit better than what my grandmother went through. So that's how it affected me.
Okay, great. And for those that are new and don't know who I am, I'm Lori LeBay, and my mom lived with dementia for 30 years. And so I came into this space as a frustrated daughter, trying to change the world to connect people to services, products, and tools and education that I think everybody deserves. So, well, let's go ahead and dive deep into this blood tests and what's going on with all of this. So, Teodora, why is a blood biomarker important, and what is a blood biomarker? We probably have some people that don't know that either.
That's exactly what I was going to start with, Lori. You read my mind. So a biomarker is just an indicator of a person's health. In the case of a blood-based biomarker, this indicator is measured by testing a person's blood. So your listeners may be familiar with blood sugar or glucose and how it can be tested from a finger prick or a blood draw. And in the field of Alzheimer's disease, a blood biomarker can test the health of the brain by identifying whether or not these amyloid plaques or tau tangles, which are the main culprits of this disease, exist. And I think it's just really encouraging to think about how fast the blood biomarker space in Alzheimer's disease has evolved. In the last 20 years, we've moved from confirming Alzheimer's disease only by testing the brain tissue of people who have died, and 15 years ago, testing cerebral spinal fluid and acquiring images of the brain of a person that's still alive. And these tests are still being used in clinical care now. And now we are at the point of translating these findings by testing a person's blood for the same biomarkers in a way that is less expensive and more accessible. And they show the same accuracy as cerebral spinal fluid, which is very promising. And this is most important in terms of timing for treatment, because research shows the treatments that are now available, now two, yay, are really are most effective in the earliest stages of the disease. There's a statistics that shows that you have to remove about 80% of the amyloid in the brain with these amyloid treatments to have a chance at recovery. So the earlier you start, the better.
Well, that's really interesting. I know people liked the spinal taps, but they also knew there was possibility of infection and all of those types of things that can crop up with that. And, this is, much less invasive. Now, is it a fingerprint like a diabetes thing, or are we talking a tube or tubes of blood?
So right now we're at the stage of a tube of blood, but it's the same tube of blood that you would get at a normal doctor's visit. It's not anything extra. So a lot of people listening might be familiar with blood tests already. However, there are groups that are trying to translate this exact same blood test into a finger prick that can be put on a piece of paper, and then that being sent to a lab, which can last for a couple of months. So we're not there yet, but we are heading in that direction.
Okay, well, that's really interesting. Go ahead, Ginger.
I had heard that actually it like a punch biopsy in 3 different places. So it's been improved since then. Is that correct?
That might be a slightly different test, actually. There's
Yeah.
another test that we use that can look for a different type of protein that is a punch biopsy. Yeah, there's a lot of work in this field, but that one might be looking for a different protein that builds.
Okay.
So this one is strictly through the blood,
Yeah.
through a blood draw. Okay,
Yeah.
good. Let's see, Ren, what do you see the value of this type of clinical care, like coming to the forefront? How do you see that changing things?
I'll say at the outset that I'm a biomarker researcher, so I think disclosures are sometimes important. But I'm pretty and I'm a clinical trialist, so I'm optimistic by nature. It's just written into me. But I really think I'm going to use the word. I think it's sort of revolutionary. The clinical diagnosis of Alzheimer's disease is good. It's what we've been using for 100 years since it was diagnosed, by identifying certain patterns of changes that occur in people. But even in those folks, it's only about 85% accurate. And there's a lot of atypical and unusual presentations that can be confusing, and people can have a diagnostic sort of odyssey until you have confirmatory biomarkers that tell you about what's actually happening in the brain. What are the proteins and how are they changing in the brain? And having that be accessible and part of routine care, I think really completely changes the nature of what we're doing, and be able to identify people very early, as Teodora mentioned, and being able to identify people accurately and get them the diagnosis quickly, and maybe even identifying people in this early stage, because when you show up with memory symptoms, you can actually be pretty far along in terms of the biology changes that are happening in the brain. And we know that those changes are probably occurring 10, maybe even 20 years before they start showing up clinically. And so it might be that our treatments move earlier and earlier in the disease before you ever show symptoms. But even right now, just being able to have a test that can augment our clinical reasoning and increase our certainty, both ourselves and the patient, and maybe qualify them for these treatments if those are appropriate for the patient. This is a really different type of care than we've been providing for the last 25, 50 years or so. It's the era of precision diagnosis, is what I've said. And having these accessible biomarkers that are not invasive, not expensive, are what's going to be able to get us there, I think.
Teodora, what about safety? There's been a lot of controversy over a lot of, medications that have come out, and people are worried about safety in terms of medications as far as testing. What do you have to say on where we're at with all of that?
So the safety of the test is very safe. It's just a blood test, that part. So the actual blood biomarker is very safe to use. Maybe Ren can speak a bit more about the actual side effects of treatments that are out there, or I can speak more about that as well. The actual blood test it has the same side effects as you would any venipuncture, so just a little swelling at the site. But really, the blood test is available now for anybody who's listening, and there are tests, ALZpathDx, and other blood-based biomarkers tests are available. and they can be prescribed for our test. They can be prescribed by a doctor filling out a simple requisition form. Our test is a very highly sensitive diagnostic tool and functions similarly to the blood glucose example that I mentioned. It's measuring a specific protein in the blood called p-tau217. This protein shows up as soon as a reaction, it shows up as a reaction to amyloid plaques building, and it's sort of in conjunction with it. So this test can indicate the likelihood of someone actually having amyloid plaques in their brain with an accuracy of about 95%. And like Ren mentioned, it can be used in myriad ways. It really just depends on the clinic or the practice that is using it. It can be used obviously to diagnose Alzheimer's. It can be used to screen individuals, like Ren mentions, for a differential diagnosis. Only 60% of cases are Alzheimer's. So it can be used for clinical trials, but really most promisingly it can be used for whether or not a person can receive these anti-amyloid treatments. And just kind of looking into the future, we're really just scratching the surface of how these can be used. We could get to the point where these blood biomarkers can be used in people without symptoms. So Ren is probably seeing people with symptoms now. A lot of clinicians are. But what about people that are, just are at risk for memory impairment disorders? And again, to echo what he said, the Alzheimer's field is just primed for precision medicine. We'll be able to stage or see how far someone is along the disease continuum, maybe even predict the progression of disease using these blood biomarkers. So it's really exciting.
Ginger, you look like you might have had a question there.
I have a question. I'm a member of Kaiser. That's my primary. They're very focused on preventative medicine. I actually contacted them, and I talked about this procedure and they turned me down because it's so new, of course. But I think the fact that if you can identify early, lifestyle changes are enormously helpful in anything to do with Alzheimer's and Lewy body. I think the value is just enormous right now.
I had a question. I was going to wait and pull in some of the questions that I gathered from the audience, but I'm going to pull this one in now because you said, the test is really to identify the plaques and the tangles. And someone, wanted to know, is it based on that theory? And they said, if so, they said, I won't trust that theory because it's been proven over and over again that it's not totally accurate with like the NUNS study and some others out there. And so what do you have to say with that? I know, from the NUNS study, it sounds like some people had the plaques and tangles and had symptoms, others did not. And so, what do you say to our audience member asking that question?
So I assume they're talking about the amyloid hypothesis.
Yep.
Yeah. Okay. So it's complicated. The NUNS study is interesting, but it's complicated. And I'll give the sciencey perspective, and then maybe Ren can give the clinical perspective because he's the one that sees these patients. So just to kind of break it down, if a person comes in through their doctor's office and they receive this test and they have some symptoms and maybe their p-tau217 is low, that doesn't mean, the clinician can use it. It's a puzzle piece to a bigger puzzle. They can test for other things. But the amyloid hypothesis at the time, it's not that it's been disproven, it's a little bit more nuanced than that. We know that the amyloid shows up first and then the tau tangles. That's something that we didn't know before. And so the way that this presents clinically can be very complicated and different in every single person. So I'll let Ren take it from there.
Yeah, it's a big topic because it covers everything in the field from the first discovery, by Dr. Alzheimer's looking under the microscope and seeing amyloid plaques and tau tangles, and then the next 125 years of research trying to learn about how they interact and cause the disease. And in some ways, I think it ties in, Ginger, to what you're saying, is that the disease probably precedes maybe even these proteins, because we don't know what really triggers their accumulation in some cases. And we know that sort of healthy lifestyle probably does help forestall, some of it's healthy lifestyle, some of it's, choose your parents well. There's probably some genetic factors that really matter. But those seem to feed into the disease process, if we think, which is these protein accumulations. And the Nun study, I think, is mentioned. There was a lot of confusion over, and a lot of argument, good argument, as researchers are trying to find out how these proteins interacted and how, they may lead to the disease. And when we started to have biomarkers in the first case, like amyloid PET scans and some of these CSF tests, we did identify a lot of people that had amyloid in their brain and didn't have any symptoms whatsoever. In fact, people in their 80s and 90s, it's common, it's actually quite common because of how prevalent the disease is to have these proteins. And so it was said, aha, these patients have amyloid, but they don't have the disease. But really, over the next 10 to 20 years, if you follow those patients longitudinally, it does seem that brain amyloidosis, that amyloid accumulation, does seem to really increase the risk of developing symptoms, in a way that almost makes it inevitable that if you have those proteins, that you're on the way to something. It's the first stage of the disease. And so this question about the amyloid cascade hypothesis was very much an open question in the field, until the advent of these amyloid targeting therapies, where they were removing the proteins from the brain, and we could observe what happened. And it was the case that in the earliest patients, you could slow the disease down a little bit. They're not a home run, they're a base hit, but they definitely cleared the amyloid from the brain, and we were able to see that actually did slow the disease down by about 25 to 35%. So there's some outstanding questions about that. The work is not done. We have to learn more about those treatments and what impact they have on the disease. But it becomes increasingly difficult to say that amyloid doesn't matter if we can remove it and the disease course actually seems to change. It isn't completely settled, but I always say this is a strong piece of evidence suggesting that this protein is probably the beginnings of the disease, though it probably is much more complex than we're aware. And we certainly know this other protein, tau, which begins changing really at the outset of symptoms, may be very important as well. And now a lot of clinical trial efforts are looking at now not just removing amyloid, but changing or modulating the tau.
I wanted to throw in a question here from our audience. And the question was, is the blood test just Alzheimer's specific? Because right now, everything used to be Alzheimer's, and now everything seems to be dementia, and they get intermixed. And then you throw in MCI and Lewy body and all the other things, and it just kind of gets the general population's head spinning. So is the blood test specific just to Alzheimer's?
So the test is specific to Alzheimer's disease and related dementia. And what that means is that it picks up. It is an indicator of Alzheimer's pathology specific. So it is not going to diagnose Parkinson's disease, for example. That is a different protein. And so really this test, because it's so highly accurate just for Alzheimer's disease pathology to begin with, it can be used to maybe filter out the fact that maybe if it's really low, maybe the patient doesn't have AD. That's one way to think about it.
How about mixed dementia?
Ginger, this is something I think about a lot because it's not uncommon. The way that we think about and teach these diseases, we associate one or a couple of proteins with certain clinical syndromes, but we know that in reality, it's much more complicated, that one protein can actually manifest in a number of different ways depending on where it accumulates in the brain. And sometimes the same clinical symptoms can be caused by a different protein. That's why these confirmatory biomarkers are so important to understand exactly what the protein is that's building up. And it's often, to make it even more complex, it's often more than one protein in people as they get older. There's more than one cause of what's going on. And vascular disease and synuclein, as you mentioned, in Lewy body disease, can interact in complex ways. And people with Alzheimer's, if we follow them to the end of their life to autopsy, we find about 40% of them have the synuclein, the Lewy body co-pathology. How does that affect the disease? And being able to have those biomarkers during life and be able to then match those with the clinical symptoms is how we better understand how these all differ and how they might be reflective of different disease processes. But we've just got those tools now to be able to identify a couple of those proteins and then be really certain about them during life. So we're really put the first step down the path to answer that question, I think, in more detail, which I think is one of the most important ones in the field right now.
Yeah, you hear so many people now getting mixed dementia or probable Alzheimer's, or everyone's coming back going, well, they think, but they don't really know. It's changed 6 times, and now they're to, I think, point of view. I look at cancer, and it started out as one thing, and look at how many different types of cancers we have. I see dementia spreading the same way, and I would imagine there's different triggers for different types, because with cancer, I mean, they're treating in a lot of different ways depending on what organ or area of the body it's attacking. And so I think people see that, and they're hearing more about dementia, and what I hear from a lot of people is they get a little suspect that there's only one major area being kind of pushed through with the amyloids and plaques. And they're starting to hear more about, the gut bio. And I mean, there's all kinds of different things, or just even social prescribing and how that can help. And everybody wants everything to work together just to settle it down, even if it doesn't go away, but just settle our lives down so that we can get back to normal. So I think there's so much information, it gets confusing, to the public. So it's good to have these conversations. One of the other questions somebody asked is, will there be counseling when somebody gets this? Kind of like with a DNA testing, there's counseling with that. Is that part of the process, or is that going to be looked at as part of the process? Because that's a big piece, especially if the person giving you the diagnosis isn't a specialist in the area. And, how is that going to affect my life? Because I know diagnosis period is an issue. Like people with dementia, their families talk about all the time. They're like, they give us a diagnosis, they give us a prescription, they give us another appointment, but we're not tapped into true help in our daily lives. So is that something that's being considered at all?
I do know of the ideas of this, and some of them are being implemented. There was an article recently by Dr. Chin, and I can send that to your audience if it's a great perspective article talking about the infrastructure of the healthcare system and how it needs to change in order to support both sides. So support both the clinical side with nurses, social workers, neuropsychologists, and then on the other side, support the caregiver and the patient with what they're called the patient care navigators, right? And there are companies, for example, Ripple, who are in the space, and they are trying to really just make sort of like a bubble of care around the patient to help them through their medical journey. So I know about ideas, and some of them are being implemented. Maybe Ren, on your side, you might know more.
Yeah, it's an entire field of investigation about disclosure and how can you do this. We know this is an impactful diagnosis. It's akin to cancer diagnosis, as you mentioned, the stigma associated with it, the impact on life. This is big. And these tests do give you an answer, and the ease in which you can get the answer doesn't change how impactful that answer is to the patient. And the truth of the matter is there just isn't enough of me, dementia specialists, right, cognitive behavioral neurologists, to be able to do the work to diagnose the millions of Americans that are diagnosed, and importantly, the millions that are undiagnosed, that haven't actually sought out a diagnosis yet. So how we do this, in the medical field, we have an understanding of how to give a diagnosis. We're trained in this. It's a lot of the training that I have is how do we kind of build a therapeutic alliance and prepare patients, for this journey, because the diagnosis is the first step. So there's a lot of effort around how do we, disclose this information in a way that's, going to be the least upsetting and most helpful for a patient, mostly having their loved ones around, doing it in a calm environment, talking about what we know about the test, what we don't know, what the path forward is. But it really is all of those next steps as well that we have to think about in terms of treatments, options, adaptations in life, preparations that we need to do. That's really the beginning of the conversation in my mind. But being able to have that certainty does take away that, we're not sure, we think it's this, it might be this. If you can move from that 75, 85% into that 95% surety range with these tests, then you can have those conversations in a concrete way and not the way we used to say, well, we think it might be this, let's wait a year, see what the direction of this, it'll declare itself, and then we'll know for sure. Now we can do it sort of up front, and we can be able to have that disclosure and have that conversation with a sense of certainty. But then how do we train everyone else? And I think it's going to be probably in primary care that we'll have to, do a lot of the, and have, historically done a lot of the workup and the diagnosis. And so how do we educate all of the clinicians out there that care for patients with thinking and memory problems about these tests, about when to use them, how to use them, how to interpret them? I think that's really the task that's in front of us. It's exciting. I mean, it's a great it's a great task to have, but it is a challenge of the next 5 years as these become easy. And I'll just say, I worry a lot about people getting this diagnosis in the absence of good clinical care or follow-up. Like I'm actually, I strongly oppose to direct-to-consumer testing. I really worry a lot about getting these diagnoses without having that disclosure process, without being able to talk about them with the clinician and integrate them into the clinical picture. Because false positives do exist and false negatives do exist. No test is perfect. And there's factors about the patient that you have to integrate when you interpret the test to be sure about them. And so I really think that we need to expand these services to be able to do the diagnosis and disclosure appropriately. I think just as Teodora was saying.
Well, this is good information. If people are just tuning in right now, you're going to want to rewind and go back to the beginning. We've been talking about the emerging role of blood tests to improve the diagnosis process for Alzheimer's disease. And we've had some great conversation here. You can go to ALZpath.bio for more information there. We're going to take a quick break and just hear about Q for Good, which is a fantastic webmaster that can work magic for you. And we'll be right back. I also want to introduce you all to Q-Blocks. They have been absolutely excellent to deal with. They have been in business for 18 years and they serve the globe. I can't say enough good things about this company. I've had a lot of bad experiences. I don't know about you with tech companies. They have made a very complicated process very easy. And their staff is so kind, so polite, so respectful to work with. And, when I am frustrated and ready to pull my hair out, they just smile and tell me everything's going to be okay. And they really are just on top of the communication, which alleviates so much stress as an owner when you're dealing with tech issues. You can get a 10% discount. Visit them at Qblocks, that's CUEBLOCKS.com, or you can email them at letstalk@qblocks.com. For that 10% discount, just put Lori, Lori, in the inquiry form. And again, I don't think you'll be disappointed. I surely haven't been. I can't rave enough about this company. And that's kind of rare these days. We've kind of talked about how important these are from a clinical perspective for the patient, the family, the doctor. But is there anything more that you want to explore there, Ren, in terms of the importance of these biomarkers and being able to monitor them over time? Oh, Ginger?
I have a question. Does the test show the severity of the amount of the amyloid, the tau, or is it just that it's there? And as the patient progresses, does the test show that?
Ginger,
You're a researcher, Ginger. We didn't know that. You have the mind of a scientist. That's great. So the research is showing that p-tau217 does track closely with disease progression. So we're not there yet. It's not confirmed yet, but that is sort of where the preliminary data is headed.
So if you take this repeatedly over time, you'll be able to see changes if there's more plaque buildup.
That is the idea, yeah, to monitor. And then also, I think Ren was going to talk about how you can even use it in treatment with anti-amyloid. Yeah.
Yeah, I think we're really exploring this. I think we're really learning about these tests. I think where we have the most evidence base is for a confirmatory diagnostic biomarker to tell us that that disease process is in fact taking place. And now that these tests are available in the so-called real world, right now that we're actually using them in the clinic, I think we do have to answer these questions. Because Ginger, you asked about staging, right? You want to know how far in the disease we are. We have in the past used a clinical staging paradigm where we go from no cognitive symptoms to subjective cognitive symptoms to mild symptoms to dementia in early, middle, and late stages as a ways of having a proxy for the biologic disease that's taking place, which is the protein accumulation. And sometimes people do better than the protein accumulation. Sometimes people do worse. And the reasons for that are very, very important. But being able to have a biologic marker to stage the disease is going to be very, very important. We have to look closely at the performance of these to see how accurate they are in being able to tell us those answers. And I think there probably is a role in the treatment clinics as well. As we said, that these could identify the Alzheimer's process, which may be able to qualify people for these anti-amyloid treatments. And this is something I'm actively researching right now, looking at very closely to see if we can use it to monitor patients and their response. Because if it's a measure of amyloid and we're removing the amyloid, can we use that to show that the drug is doing what we think it's doing, which is clearing the amyloid from the brain? We do have gold standard tests, I should say, amyloid PET scan, tau PET scans. These seem to be the most accurate at doing these tasks, but amyloid PET scan has only just been recently covered by Medicare, sometimes difficult to get in other insurances, quite costly, only available at certain centers. So blood tests are preferable when you're thinking about scaling out to the entire world. And tau PET really is mostly used in research. I think a very powerful tool, but quite costly. But maybe our gold standard for staging that we can use as a bridge to get these blood biomarkers into this role. But this is an active area of research. I mean, really, we're talking about like the last 6 months or a year that they have been available for us. So we're, very actively, very furiously trying to find the answers to these questions because I know how important they are.
Wonderful. Thank you. Ginger, did you have any other questions that came to mind?
I want maybe on a personal level, I can describe something that happened to me. I ended up with so many symptoms of Lewy body that I ended up in a nursing home for 2 years, bedridden, flat on my back, unable to eat. Mysteriously, I got better. If I would just love for you to include Lewy body somehow in your research. I know you're thinking of it, obviously, but that would have saved me a year that I could have come home if that could be diagnosed as actually improving, which I have faith in someday that that's going to be possible with us, that there will be improvements and we're just not, warehoused forever. So, I'm really enthusiastic about this whole thing. On a personal level, you can imagine.
Great, thank you.
Just to say that I don't know, maybe Teodora has something behind the scenes about what's happening, but there are biomarkers for Lewy body that are sort of emerging into the clinic, but they're mostly based around CSF testing and the biopsy testing, Ginger, that you mentioned earlier. And having a blood biomarker would be key for that just because of accessibility and scalability. But we're very much thinking about that protein just as well. And I actually think about a lot of non-AD proteins, TDP and non-AD tauopathies and inflammation. These all may be just as important understanding the disease. And sometimes a flashlight can be illuminating and sometimes it can be blinding. And so we really have to keep our mind open and think about all these other proteins, even as we're able to identify this one disease, Alzheimer's, with really startling diagnostic accuracy now.
Great.
Yeah, and sorry, Lori, just to add that really we're tied to the tools that we have. And right now we are really advancing the technology of figuring out which protein is related to what disease specifically. So because we have such high specificity tools now, we can actually see much better. It's like sort of, somebody has zoomed in very closely and the clouds have lifted and we can actually see what's going on. And that can allow us to make not only the assay and the test to test for these diseases, but the treatment to specifically target the thing that, is messing up the brain in that particular disease.
Great, thank you. I have a few other questions that my audience sent in, and a lot of people said, "Yay, less invasive," but they also wanted to know what's the turnaround time for something like this, in terms of being able to hear back. Does it have to go to ALZpath, or can they test it right in the clinic? And
yeah, that's a great question. And I know the logistics part is not a very exciting part to talk about, but it's very important. So the turnaround time is between 5 to 10 days. The test is taken at either the doctor clinic, or if the doctor doesn't have a phlebotomist on site, they can go to a nearby lab to get their blood drawn. The kit that is sent has everything that it needs to be sent overnight to our partner lab. Our partner lab then gets the analysis results, and then that result is securely faxed to the doctor, and the doctor will share with the patient the results. The report that we also send the clinician a report and a sample report to make sure that they understand what they're reading. These are very new tests, and like Ren said, perhaps they don't know what a high or a low test means. We actually have 3 zones. We have a high, low, and intermediate zone for our test. Other tests are different, so I'm just speaking about our tests to begin with. But each one has a particular number associated with it, or a cutoff score. And each one we advise the clinician to use their best clinical judgment based on everything else that they see about the patient to make a diagnosis.
Ren, anything you wanted to add to that?
It's fast, just as she said. It's quite fast. To your listener's question, we can get these. The workup for patients that come in with thinking and memory problems is not months any longer, years even sometimes, where you wait for the diagnostic picture to kind of clarify itself, and you kind of manage the uncertainty during that time. But now it's very quick that you can get answers for patients, I think, and even now that there's a pressure because of the disease modifying therapies, a lot of patients very interested in them. We're fairly quick at that at this center, but it's we're one center. We need to build the capacity. So sometimes it's actually getting into somebody that can order the test and interpret it that is actually the lag time, as opposed to the test itself. And part of that might be that we really just need to teach primary care physicians who are more than capable of giving diagnoses and have throughout their life and have used blood tests as adjuncts to their clinical evaluation. That might be the model, just given the scale of the problem that we have. But we're just beginning. I think it's really been, I'm looking in the past year of just in our dementia, in our memory and aging center clinic here at UCSF, what our biomarker usage has been, and it really skyrocketed after their inception, once their availability became once the test became available. And I imagine that will happen in primary care too, but there has to be a comfort with the test as well, and understanding it, and where the limitations are, and when to order it. There are appropriate use recommendations that are out there. Like, we really think these are for symptomatic patients. Screening of asymptomatic patients is not something we recommend at this time. But there are sort of guidelines. It's a matter of kind of promulgating it out to the field. But once you make that decision to get the test back, to get the answer, it's pretty quick at this point. It's actually quite quick.
I know one of the problems now is getting into a neurologist. People can get into even their primary. It can take a while to get in, but to get into a neurologist, you can be months down the road. And that's really, really frustrating for people, because that's kind of the next step if their primary doesn't know enough in terms of how to guide them for next steps. I mean, it's fine to get a medication and get a treatment, but that, in my opinion, is this much of the problem. And to me, and I've heard this from people all over the world, and I don't know if doctors really understand the impact of when they give a diagnosis, what actually happens to that person and their family. But I can't tell you how many people I have talked to that said, again, we got our prescription, we got the diagnosis, we got another appointment, and we went out to the car and we cried for 2 hours before we could even drive home. I mean, that is the impact, and that is wrong. And that is not safe for people to be driving in that condition either. And this needs to be looked at in a much more serious fashion. And also the other piece of this that I think I would like to see brought into this as you're educating is doctors have to be aware of their nonverbal language, because people are reading no hope. Even if they're getting a treatment, they're still told to get their affairs in order, and it's end of life. And so again, I'm a passionate advocate to get social prescribing, put in, or other resources. I don't care if it's a support group, an arts engagement, dementia friendly groups. There are so many services, products, and tools out there that can help people, but they don't know where to find them and they don't know where to go. And I know the dementia guide through CMS is supposed to be tackling that. But I also haven't heard that that's rolling out the way it's going to, which I'm not surprised with because it's a huge project. And I think clinics are on board, but I don't think the supportive services have gotten connected to the clinics or don't even know how to get connected to the clinics. But that is a piece that I personally would like to see pharma pair up with, because I think they will see more powerful results faster. And I also think that it will change the perceptions people have of pharma and testing and our healthcare system as a whole. Because I don't think that they feel there's this collaborative effort. Yet if you have cancer, hey, we'll help you get a wig, we'll help you do this, we're going to have a lavender cloth to calm you down, before your test. There are all these things that are baked in that have been wonderful, and they're not even close to there with dementia. And it's shameful in my eyes, because families are really left on their own. So again, that was something that I kept hearing from people as well on this, is how, and why they wanted to know how the diagnosis is going to be given, because it truly affects their emotional state for a long, long time. And so it's nice to hear that there are some ecosystems being built out in clinics that are being more supportive, but we don't have near enough of them. One of the other questions somebody asked was, in the future, would there be more tests that would be done? Maybe, if it's a spinal tap, if it's imagery, any of those things. And the reason they asked is they said, if so, then I look at it as just one more test we have to put our people through. Mm-hmm. And is that worth it? And I don't have the answer to that. So any comments from either of you on that one?
So I'd like to say a little bit more about what you said before. I think that's really important, and working together, working collaboratively is something that a lot of people are trying to do. There's consortiums and all kinds of things that bring people together from the different parts of all the Alzheimer's sphere. But from my sphere, from the biomarker sphere, using biomarkers actually does help reduce the burden, because it decreases the need for imaging, for example, to answer basically your second question. It increases referrals to counseling, because people kind of have a clearer picture of what's happening. So it's kind of one step at a time. If you can lessen the burden on the primary care and then educate them, and then the rest kind of falls into place. And then just to kind of get more specific about the other tests, this is still an active area. What we recommend is, if someone falls in the intermediate zone of our test, that means that the picture is not clear enough at this point, and they do need to go for another test. However, this does help, because if the test is very negative or very positive, if it falls within those buckets, then that means no tests, right? So from a clinical perspective, I think either way, it does definitely clarify things. Ren?
Yeah, I agree. There was a panel that was convened by the CEO initiative, and there was a recommendation by experts about what the diagnostic accuracy that would be to be a standalone confirmatory test. Are there going to be more tests? Sometimes there's other questions that need to get answered. There's additional tests. I really am very sensitive to the burden that creates for patients, but it does look like these tests, and they vary widely in their diagnostic accuracy, that some of them may be sufficient for standalone confirmatory diagnosis and wouldn't necessarily need additional testing, though you might if you want to engage in treatments. But like Teodora, actually, I want to engage, Lori, with what you had said, because this is such a huge topic about what I think is the chronic underfunding of Alzheimer's care and research in the United States, which has only just in the last couple of years begun to change to be able to address some of these questions. But the scale of the problem is completely unmet right now by the structures that are designed to serve the need. And you see the grassroots efforts from patients and their families, Alzheimer's Association, locally Family Caregiver Alliance, people that come together to try to provide the support that the medical system is just not offering. And just as a patient that I took care of that had a sort of unusual presentation of Alzheimer's disease called corticobasal syndrome, around the second or third visit, I connected them with palliative care because they were having a lot of issues, and palliative care is often very good about thinking about symptoms. And in the cancer field, as you mentioned, is often paired with the initial evaluation and diagnosis. It's immediate. And that patient's feedback to me was, I wish that would have been the first appointment that I had after talking with you, because it was so helpful in thinking about the big scale of things and thinking about the future and thinking about the symptoms. And I agree completely. And I wish that there was a structure that system could bear, directing the millions of patients with Alzheimer's disease to it. But it's that structure is just not sufficient at that time. So finding ways to build those structures to provide that support, which, as you said, is so critical, and in many ways, as you said, more important than the treatments, I think is the biggest task that we've had. But it's been the task for 50 years. And I think I don't know, there's this like myths of futility and futility. Oh, there's nothing we can do. Oh, it's inevitable, which I just do not believe, and I've never believed. I think those myths are starting to shatter, and we're starting to see this more akin to cancer as something that we can understand, something that we can diagnose, something that we can identify, something that we can treat, and find better ways to support people than this, diagnose and then, the story of somebody crying in their car afterwards is heartbreaking, right? Yeah. This shouldn't be the way that we deliver the diagnosis.
Yeah. And it's, when you mentioned the palliative care, I think one of the things that was so important with that is people feel heard and they're allowed to feel their emotions. And that doesn't always happen in a clinical, setting, nor is there time, and I mean, doctors have limited time. Everybody understands that. But I think the other thing that I personally have been frustrated with over the years, as a family member myself, but seeing it, my mom's been gone now over 10 years, seeing it and hearing it from others, is they don't necessarily want a medical academic support system telling them by the book what's going to happen and how they should do it. They want to hear from people in the trenches that don't judge, that say, you know what, we can't fix it, but we can support you, we hear you, we can learn from one another, and they don't feel alone. And I think that's one of the biggest things that's missing in our medical model, is they don't feel part of the tribe. They feel diagnosed. They feel you're up here, they're down here, and we're not really communicating on a personal, everyday level. And again, they understand the time limits and things like that. But I think so much, and I think we've come a long ways, but I still think so much of the in the trenches everyday story is poo-pooed. And it shouldn't be, because that's what I am hearing from people all around the world, that gives them hope, gives them strength, empowers them like Ginger to stand up, step in, step out, and be part of the conversation, instead of just curling up, getting ready to die, or watch somebody, prepare to die. That is not a way to live life. And so I think that, I really would love, that's probably the thing I pray about the most every day, is for that collaboration to come together and for one side not to be fearful of the other, because everyone's doing what they're good at, but we can do so much better if we all do it together. And for there not to be ownership of this space, that everyone's ideas are important. You know, what will help your family, or Ginger's family, or Teodora's family. We're all different and we have a right to those choices. And I think so often, especially through grant funding, it's in a box and it's checked off in terms of how it's going to work and how it's going to be monitored. And they're not even allowed to be fluid when they see that it's not working, to be able to change. And so from a systems level, I think there's so many more beautiful things that we can do. And there's so many resources that are free for people. So, and I'll just give a plug for Dementia Map and even Alzheimer's Speaks. We have tons of free resources on both of those things for people to be able to tap into. And we want even more clinics listed in there. But a lot of them don't have the time. You know, it takes 15 minutes to put yourself in, but families are looking, where do we go? Where do we find the specialties? Where do we find these treatments, these tests? They want that information. And it's scary to go to Google. You know, you don't know what to trust or what not. But let me get back to a couple, because we've got a couple more questions. Are all insurances covering this blood test at this point, or is this a private pay?
So our test is currently not covered by insurance. I think Ren was talking about the imaging, the PET scan that was recently covered by CMS. Our test ranges between $200 and $500, and it is patient pay currently. However, we are hopeful in the next couple of weeks even that it will be covered by insurance. And I will say that for most of these tests, I think there will be such great demand that the insurance companies do have to step in, and because it all has to, like you said, work together. Insurance has to cover, so the blood test can lead to a diagnosis, and et cetera.
Well, and if we can cut down on some of these other tests, you know, initially that might not necessarily be warranted yet, but they keep being redone, that's going to save the insurance companies money. It's going to help everybody have a healthier look, you know, at what they're living with, be able to find more support. And I don't know, maybe that's not what the insurance companies want. You know, there's always that thing of, you know, are they really helped to make us well or to keep us sick? You know, what's the true cycle the public asks on those things? But you know, I think it's really important for that to be affordable. And you know, for some people that's going to be out of reach, and other people will go, that's pocket change to give me an answer. Everybody in the family throw in $5. You know, we're going forward with this, because the ripple effect is so large in terms of who all this affects, and they want to know. Another question was, okay, if my parents have the biomarker, will I? You know, kind of like with DNA, you know, am I going to be likely if they have the biomarker, or is it really their lifestyle and their body chemistry individually, or could that be passed on to me, was another question.
You know, I would say the vast majority of cases are what we call sporadic, in that they don't run strongly in families. And, you know, as evidenced at the top, it's not uncommon to have a family member affected by in fact, it's very common to have a family member affected by the disease. And that doesn't mean necessarily that you're going to have the disease. Even the risk factor genes, the ApoE genes that we know confer an increased risk, you know, there's some argument about this, but aren't necessarily destiny. So just because your parents have the disease, or a brother or sister has the disease, doesn't mean you're going to get the disease. It's a really complex interaction between genes and environment that we don't fully understand that predicts that. So that doesn't, you know, that result isn't necessarily reflective of the rest of the family's risk. If you do certain gene testing, sometimes that can tell a little bit about risk with the ApoE gene. We do that really cautiously, but I think that the shortest answer is no.
Okay. And I've always heard, you know, I have a couple of doctor friends who have ended up with dementia, but they've always said your genes aren't your destiny, you know, necessarily. I mean, if they tested us, we probably all have a cancer gene floating around us someplace. And is it going to mutate and go active? Who knows?
I'll also add, just as Ginger mentioned before, the importance of lifestyle interventions. And there's some promising research that shows that the actual biomarker level may fluctuate with lifestyle intervention. So just something to think about, that nothing is really set in stone. You really have to get a good picture of what's happening and then work with that.
This last question I thought was really interesting. And it said, okay, let's say this all kind of starts getting worked into our physicals eventually, because I can see that happening. But their question was, okay, now how's this going to affect my insurance, my driving, my independence? How is this information, how am I going to be safeguarded with this information not going further than I want? And everyone knows about HIPAA, but again, there's kind of this distrust out there, and people know that if they have a diagnosis, well, long-term insurance is off the chart, right now for them to grab. And some doctors will even say, you know what, I'm not going to put this in your chart until you go get your long-term insurance, just in case, if that's what you want, or get your affairs in order, and we'll kind of step through this with you. But people are really worried about driving because here in America, we don't have great transportation systems. And, there has been chit chat about, upon diagnosis, there are some physicians that feel you should not be driving, where others say, no, you're still cognitively able, because there's so many levels of the disease. So what do you say to somebody who's worried about, if I get this test, how is this going to affect me? Not, they're worried past the stigma of, because they can control, are they going to announce this to the public or not? But how is this going to affect my data, which everybody seems to be able to access these days and connect to?
Yeah, I'll say, the answer, really varies a lot on where you are. The laws on driving and diagnosis really matter where you are. So really, to talk to your doctor is a lot of the question about the diagnosis. But I'm very sensitive to the impact of diagnosis, both psychologically and, as you said, sort of financially. And all these considerations have to be taken into account before you decide to order the test, and hopefully do it, after discussion with your doctor or clinician about what the impact's going to be on you. And I think Teodora said, the test is not a diagnosis. It's a biomarker result. It's a puzzle piece that you put in together with all the pieces. And importantly, you have to stage the disease, because if you say cancer, this is just a word. You say dementia, but there's stages of this. Some people are so early that we can't even detect changes on our, highly sensitive cognitive tests, that they're in this subjective cognitive decline stage, where I believe them if they say that they're showing symptoms. And sometimes we're doing the testing and finding those proteins in patients before they ever have any overt changes on our tests. And so this is, it's stage 1 is different than stage 4 in cancer. And approaching everyone as if they have stage 4, as if they have end-stage dementia, is part of the problem of the stigma of this disease, is that stage of the disease is not the same as subjective cognitive decline or mild cognitive impairment, where you are actually, by definition, largely functionally intact and able to do things like drive potentially. The decision to pursue the diagnosis is complicated. The insurance one is why I encourage everyone to get long-term insurance. That's how I solve that problem. I say, no one knows how we get out of life, but I know we don't get out of it alive. So long-term insurance is a good decision for everyone. But that's one sort of facet to decide. And I found though, and maybe this is just my experience, is that sometimes the diagnosis is therapeutic for a patient, because it gives them an explanation for what's been going on for them and their loved ones, and they can begin to plan. And so sometimes, you can actually see a relief to actually have an understanding of what's going on, though of course the diagnosis, you have to deal with the reality of that, the impact of it. But so I would encourage to people just engage in that discussion, because you don't necessarily need to pursue. Sometimes the decision is to wait, or to give it 6 months, or to get other affairs in order, as you said. I think that's all perfectly appropriate. The decision changes a little bit if you're thinking about treatment options, because again, the earlier the better, and that might increase the desire to get the the precision diagnosis required. That is a very complicated conversation that we're having with patients right now, and all those factors need to be taken into account before you order the test and come to that diagnosis if that's what the result is.
And I'll add that we know that we're sort of on the verge of this transformative era in Alzheimer's field, mostly because of these questions, right? We're wrapping in ethical considerations of how insurance is going to impact the rest of their life, et cetera. But we're also at the very beginning, which means the transformation is happening now. So it's just exciting that these biomarkers and the treatments that are unfolding are a part of that.
It's good. I'm glad we had this conversation, and I really appreciate, Ren, that you brought up the relief some people get of having a diagnosis or being able to take that next step to get a diagnosis, because we hear that all the time. It's like, I'm tired of feeling like I'm crazy. You know, people go, you look fine. You know, I forget my keys too. You know, all of those types of things that they're hearing, and they're like, it's different, but they can't always put it into words. Ginger, any last comments from you?
Well, I'm just so thrilled that it's existing. I think that just can change the world because, as we know, the older we get, the more Alzheimer's and all these dementia diseases are affecting the population. I mean, if I think it's beautiful. I'm just so glad you're here. I did want to mention one thing that happened to me when I was diagnosed. That was it. The doctor say, go home, wear a house shirt. That's nothing. They offered nothing to me. And thank goodness for people like Lori and people like Dementia Association. There are outlets for people now. That's a good thing that happened in this world. So thank you, Lori, for bringing these beautiful people to this program, because I think they're very exciting.
Yeah, well, I'm a firm believer that we can't make sustainable change if we don't include all voices. You know, we're just all going to be spinning in our own little silos, and we're not going to be making the progress that we could. And so, again, I'm thankful for this conversation today too. I think we covered a lot of ground and answered a lot of questions that people had regarding these tests. And, you know, you can go to ALZpath.bio for more information. You can fill out their contact form if you have more questions. And we also will have in the show notes some LinkedIn pages for both Ren and Teodora. So, you know, and Ginger, you can get a hold of her on Facebook, or feel free to reach out to me. I can pass information on as well. As always, I want to thank each of our panelists, and I want to thank our listeners. And I really hope that you will join us in being a giver of hope. Like, click, and share. You know, don't keep information to yourself. You know, it doesn't do near the amount of good it could when you share. And there's people in your sphere of influences. I don't care if it's Facebook. I don't care if it's a family member, Twitter, or Instagram, or LinkedIn. There are people out there that need this information and don't even know they can ask for it because they don't know it's available. And that is all our responsibility, to share what we know, to make people's lives easier. Because boy, when this hits you, it's tough. It's tough, and you need the support. And it doesn't cost any money, and it takes very little time. So again, join us in being a giver of hope, and in moving dementia forward from, you know, crisis to comfort around the world. You know, we're doing it. It's not moving as fast as any of us would like, but we're pushing that ball up the hill, and pretty soon it's going to be coming down the other side. So thank you, everyone, so much for your time today. I really appreciate it.
Thank you, Lori.
Great, thank you.